go over there. What we are having here is 4 individuals deeply dedicated and involved in epilepsy and epilepsy research and epilepsy outreach. Simon PRIVETT from Exeter, UK, who joined us here, and we will start a conversation in a second. Professor Fabrice BARTOLOMEI, who is chef de service at the clinic here in Marseille, APHM, second largest public hospital, with a very large epilepsy service in there. And Dr. Julia MAKHALOVA, who's also a researcher, a clinician working in the service. And Professor John Terry from the University of Birmingham, the director of the Systems Modeling and Quantitative Biomedicine Center over there, also with a very long history in contributing to epilepsy. The way I wish to do that is we will give presentations, we will give you an overview of some of the work that happens in epilepsy, but in particular I would like to start with Simon. So it's a pleasure to have you here, Simon. Simon has been very involved in various capacities in epilepsy, in promoting awareness of epilepsy, participating and leading, coordinating group efforts, support group for epilepsy. He has also been, more than 2 decades ago, I believe, diagnosed with epilepsy and has lived experience in epilepsy. And maybe I can give you the word and you can start with some insights in what does it mean actually for you to have been diagnosed with epilepsy and to live with epilepsy.
Okay, thank you, Victor. I think the first thing I'm going to say is one of the things that affects me living with epilepsy is my memory. So I'll apologise for having a few notes written down. I feel to some degree a little bit of a fraud sat amongst my esteemed panelists this morning because I'm not a clinician, I'm not a researcher, but I am in some ways still an expert. As Victor's explained, I've spent more than 20 years living with seizures myself, so that's enough experience for me. I would like to say that amongst the things that I will say today, they speak from my experiences, but it's always worth remembering that epilepsy affects an estimated 65 million people globally, with around 5 million diagnoses each year. So my experiences will differ from many, many others who suffer from different forms of epilepsy. In terms of what it's like to receive a diagnosis, I'd like, if I can, for a brief moment, to invite everyone to join me in a thought experiment, particularly those that don't have lived experience. Imagine it's a normal work day. You've arrived at your office, wherever you work. You've maybe got yourself a coffee and you're greeting colleagues, and everything is just a normal, typical, average, ordinary day. And then suddenly, it's not. You wake up in an unfamiliar location. Every muscle in your body hurts. You've got the worst headache you've experienced in your life. You have no idea where you are. You're surrounded by unfamiliar people. For so many every year, that's the first experience they have of epilepsy. And for many of those, they have absolutely no prior knowledge of what epilepsy is, and it's the start of a very difficult journey of learning a very new way of life.
Thank you. Thank you, Simon, for sharing this. The reason we are having this discussion is actually many of us are working in, well, we just had this. Stephanie, you said it. It's important to predict for the patient, to help the patient. So it is also very important for all of us here to link it back to the patient, to link our science back to the community that is actually on the recipient end. And one aspect that matters there, we are spending years of work on generating technology and science, and we have certain beliefs of what is important then in the actual translation to the patient. Yeah? But can you give us actually the patient perspective of what really matters from your perspective, the technology that is being generated? We have certain imaginations, but from your perspective, when you go through the clinical routine of diagnosis and therapy, what are the aspects that are really touching your life and where we can, which are important for you, where we could improve?
So I think the biggest thing that stands out for me from thousands of conversations with people with epilepsy is the lack of specificity of diagnostic testing. So if you have, say, a fall and you've hurt your leg, you go for an X-ray, and the X-ray shows broken leg, not broken leg. It's a very positive or negative result. And one of the things that a lot of people with presenting with seizures struggle with is they'll go for an MRI, and the neurologist will tell them, "Yep, no, nothing's come up on the MRI. That's all clean." They'll go for an EEG, and quite commonly the answer will come back, "Yeah, there's nothing untoward showing up on EEG." So they'll take as many notes as they can as to how the seizures present. And ultimately, yeah, it's most likely epilepsy. We'll make a diagnosis. Here are some medications. And patients are left confused that they have a diagnosis of a condition, but they haven't got some kind of evidential basis for this. It kind of almost feels more like guesswork, in a kind of, we've got nothing to show that it's definitely epilepsy, unless people have gone for some kind of long-term EEG recording. So for most people, my diagnosis was based on evidential reporting from my parents, essentially.
And this period of non-specificity, how long does it last? Is there an end at some point?
I mean, ultimately, no, for most people, unless they can capture EEG data of a seizure happening. And I know some of the people to my left will be talking about this later, so I'm not going to go too much into detail. But I mean, I was diagnosed in 1996, and there's still no evidential basis for my diagnosis. There's the potential that it could be something else, for example, non-epileptic attack disorder. So it can go on essentially indefinitely.
Okay, but then there must have been some route towards treating you.
I mean, essentially, it's just looking at the symptoms and the way the seizures present and going, okay, epilepsy seems the most likely. We'll treat for seizures with anti-seizure medication, and hopefully you will remain seizure-free at some point. But for me, it took in excess of 20 years. I'm now 4 years seizure-free, but that was a long time to wait for seizure freedom.
Mm-hmm. So time delays and the time scale is an important aspect. Acceleration towards diagnostics
absolutely.
And treatment.
Yeah, a faster and more reliable diagnosis, I think, is what people with epilepsy want. And I guess for people like me, it's been going on for so long now. There's essentially, I don't want to use this phrase, but kind of no hope for us. There's nothing that's going to improve my life now, but I would like to see better outcomes for people yet to be diagnosed with epilepsy.
Mm-hmm. Okay, thank you. This is very important. Maybe as a final question, you've participated here since yesterday. Yeah? What is your view, from your perspective, on the progress of technologies and research that you have seen here? What is the view of the community, maybe, with regard to digital neuroscience, what we can contribute?
I think I'm in a very privileged position as a member of the public, essentially, to be able to see the amount of work that's going on in this field. And I think if people with epilepsy more broadly were aware of the amount of work going on and the efforts of everyone present to work in their respective fields, people would be incredibly heartened by that. I think there's an assumption that no research is going on, because with epilepsy specifically, there feels like there's been very little change over the last 30 years in how epilepsy is treated. Currently, it's still a kind of try this medication. Oh, that hasn't worked. Okay, try this medication. Try this different medication. So it's very, very positive for me to be able to see that there is research going on, that there are people that care. The only caveat for me is, I'm sure John at the end there will agree with me on this one, is that I see my kind of raison d'etre in this position is to remind researchers that when they're looking at EEG data, as a for instance, that's not just a set of wavy lines on a piece of paper. There's a human attached to that with hopes and dreams and a life. So for them, it may be a diagnostic tool, but for those of us living with the condition, it's a life event.
Thank you. This was, I believe, very important for us to hear.
Thank you, Victor.
Thank you. Fabrice, I suggest you, as one of the world, as one of the world-leading experts in the field, you have prepared a presentation. So do I. And if you could give us the perspective from the clinical research and the theoretical approaches towards that.
Yes. Thank you very much. Do you hear me? Okay. Okay. So with Julia, we divided our talk in two parts, and I would give you a brief overview of the problem that we face in the epilepsy surgery domain and how we can use quantification and modeling to progress in this field. And in the second part, Julia will show you one practical case to illustrate my talk. Well, it doesn't work.
Because this is a laser pointer.
Sorry.
Left button.
Okay. It's a big technique, yeah. So, as you know, epilepsy surgery is a main curative technique that we can use in patients with focal drug-resistant epilepsy to cure this patient. The objective is to identify and to localize the epileptogenic zone, which is the region in the brain that generates seizures. And to do that, we use different investigations, non-invasive and very frequently invasive recordings. And I will essentially talk about invasive recordings today. We have to acknowledge that there is only modest improvement over the last 20 years in the progress in surgical outcome. It's a very stable result. So that's why we think that we need really to progress at this stage. So as I mentioned, we use frequently depth electrodes recording. It doesn't work also? Yes. Okay, I will use just where the principle is to implant depth electrodes in the brain and to record the EEG signals directly in the brain. And as you can see in this picture, we can, by this way, identify some region that generates seizure. And generally, the seizure is characterized by change in rhythms and the appearance of fast discharge in the beta or gamma band. When we operate patients after a CEG, however, again, we don't have very, very good results. We have some failure. Approximately 40 to 50% of patients are not completely cured after surgery. So again, here, we really need to progress in the interpretation of such recordings and in the guidance of surgery after. So to do that, we need, first of all, some conceptual framework. And in the last, I would say, 20 years, we use a lot of quantification and study from this kind of recordings. And the evidence now is that these diseases are not so focal. We face generally networks, and particularly we describe this concept of epileptogenic networks where we have several subnetworks in the brain of patients with focal epilepsy. With a hierarchy of epileptogenicity, we have some regions that are the higher epileptogenic region in the brain that form the epileptogenic networks and generate seizures. And from this network, we have the invasion by the discharge of other regions that are less epileptogenic, and we have called it the propagation zone network. The objective of epilepsy surgery is to identify this network of this epileptogenic zone network and to guide the surgery to cure the patient. And in this field, there were an explosion of techniques, or computational techniques, to find good biomarkers for the identification of this epileptogenic zone network. We can use enterictal quantification based on the detection of spikes and also high-frequency oscillation. I won't detail it. Also, we can use methods to better quantify the seizure onset regions, and I will briefly talk about this point today. To do that, we can use several methods of brain network quantification. We can use local activation identification, the node properties. We can use pairwise interaction and the use of functional connectivity approach. And we can use also more global topological approach using graph theory methods. We have to acknowledge that for the clinicians, the interpretation of these kind of techniques are decreasing from these node properties to the most elaborated ones, I would say. So generally, in clinical setting, we prefer to use this node properties approach that I will briefly describe. The first method in this way was the epileptogenicity index method that I and my group published 15 years ago now. And it was based on the detection of fast oscillation at the seizure onset. And this method was followed by several declinaisons and other methods that can use some principle of these techniques. So the epileptogenicity index, just as an example here, is a method based on the combination of two mathematical parameters. The first is the detection of the increased ratio of fast activity, as you can see in this picture. You see this ratio of beta-gamma activity increase in some channels. And the second parameter we use is the time delay between these increase. And the epileptogenicity index is the division of the ratio of fast activity by the time delay of involvement. So we can normalize this kind of quantity and express these values for each channel, as you can see here. And the interest of such method is the possibility to project the values into the MRI of the patient. So we pass from a 2D vision and complex vision of the EEG to a simplification into the anatomy of the patient, but you see that it is at the level of electrodes, and in this case, it is in the mesial temporal region. So this kind of approach is very important, and we have made progress in my service by using systematically in routine such quantification. But of course, there are some limitations that we know, and particularly because with this method, we analyze only what we record. It's the problem of the sampling by these techniques that we have electrodes in some region of the brain. And we don't take into account the whole brain anatomy and interaction. To overcome this problem, we can use a computational modeling process. And the idea here is to build a digital virtual brain twin, where here, with this model, we can have an estimation of the epileptogenicity at the brain level, the whole brain level, and potentially the question is, can we use it to guide surgery? This kind of model, we are probably aware of this type of approach, of course, is a brain network model that makes the use of the combination of neural mass model or more abstract model into the anatomy of the patient, and particularly using the tractography and the parcellation of the cortex. But such techniques that it's developed in Marseille with Victor and Julia and all the team in Marseille, and particularly in this program called EPINOV, which is a French grant RHU. And we have developed the virtual epileptic patient modeling, the VEP modeling, in order to improve our surgical approach, and also there are some industrial development in parallel. So to be very brief, and you can ask, of course, Victor if you have a question about the technique, but in this modeling we have several aspects. The first is that we take the individual data of the patient. That's very important. It's an individual modeling. We take the MRI, and particularly we can do parcellation of the cortex, obtaining some nodes of the network, and we use tractography to have the connections. The second aspect is the equipment of this node by the Epileptor model. It's a neural mass model, as you know. And the excitability of this model is depending on the connectivity, but will depend on the data obtained from the patient. So the third step is to have a data fitting between the data of the patient. Essentially today we use intracerebral EEG recordings and ictal EEG. And this data fitting is done by the Victor's group using Bayesian inference. This pipeline of the model has been published recently. It has been developed over the last 5 years. And you see when we enter the data in this pipeline of the patient, at the end we have this clinical report where there is an estimation of the most epileptogenic region for our patient that can be expressed as you see in this table, or also projected in a 3D vision of the brain. Is it working? That's the question, of course. Can we use it in clinic? That's what first we tested into a retrospective study. Here we studied 53 patients, and we compare the result of the VEP with the estimation of the epileptogenic zone by epileptogenicity index. We have some correspondence, I won't detail. For example, the precision is around 0.6. But what is important and validation of this approach is that if we compare the non-seizure free and seizure free patient, we have more non-resected epileptogenic region given by VEP in the non-seizure free patient. And this is also observed in regions that are given only by VEP and not given by our analysis. And some of these regions are not sampled by our electrodes. That's is a very interesting finding, of course. So currently, this pipeline, this first version of the VEP is tested into a prospective study. This is the EPINOV study, which involves several centers in France. Today we have more than 300 patients that has been included, so the inclusion are quite finished now. And the idea is to randomize patients after ECG into 2 groups. One of these groups is the control group, and the other is the VEP group, where the clinician have the result of the VEP during the surgical meeting for the decision of the surgery. So, and at the end we will compare these 2 groups, of course, to estimate the added value of this VEP modeling. So I think this study will be published in 1 or 2 years now. I would like just to conclude briefly. I wanted to show you that this kind of approach is feasible in clinic and complement our classical approach. We have this clinical trial, we have new development that I won't detail, but particularly we want to develop the completely non-invasive VEP. That's very important, to try to avoid the intracerebral step. And I thank all people working with me and all the teams in Marseille, and I let the floor to Julia now for the clinical case. Thanks for your attention.
Thank you. And Julia, you will present in direct application a clinical use case. Thank you.
Good morning. You hear me? It's all right. So just the mouse. Yeah. So I'm going to present you now the use case. It doesn't work.
Just press the left mouse button.
Yeah. Okay. Thank you. So this is an illustrative case of a 29-year-old lady who is suffering from drug-resistant epilepsy since the age of 2 years with very disabling seizures, just like Simon mentioned. Very disabling seizures predominant in the night with very unpleasant paresthesia in her back, followed by hyperkinetic movements of her limbs and body, and also dystonic posturing of her arms, grimacing evocalization. And the seizure frequency is very high. You can see that there are several seizures per week of course, under anti-epileptic medication. And this patient underwent a pre-surgical workup, showing that from her scalp VDG data, probably seizure could start from the left frontal region. And on her ultra-high resolution MR imaging, we found this abnormality within the left orbitofrontal cortex, which could be maybe the cortical dysplasia, a very epileptogenic lesion. And the FDG PET functional imaging showed hypometabolism within this region, but also within the left temporal lobe. And so we performed additional non-invasive whole brain imaging. It's electromagnetic source imaging, including high-resolution EEG and magnetoencephalography. And here the results were somewhat discordant from what we saw on her structural MRI. And you can see there is this source localization within the left inferior frontal sulcus. Here was the region of the dysplasia shown in green, and there are other sources just in front of the supposed lesion and also on the cingulate cortex, but also some sources found in the parietal and temporal lobes. So you see that it's already not so easy in this case, and so we decided to go to the stereo-EEG recordings with our principal hypothesis at this stage of left prefrontal epileptogenic zone network, but we also questioning the insular involvement because of the symptoms the patient described, and also, of course, the role of the temporal lobe. So 12 left hemispheric electrodes were implanted and also 2 right electrodes to see the whole network. And here I show you the example of a real ECG interictal recording from her sleep. And you can see that there is a very active spiking activity over the left orbitofrontal region, which is the region of suspected lesion, but also there is a spike activity over the left anterior insular, and even in the left amygdala we have also interictal paroxysmal activity. And now we have this spontaneous seizure, habitual seizure of the patient recorded on the ECG. And again, you can see here very complex organization at seizure onset with these poly spikes, bursts over the lesional region in the frontal lobe, but also in the insula, and then starting to this, evolving to this tonic, very fast, low voltage fast activity involving both regions, frontal and insular. So let's have a look what the quantification of ECG signal can tell us, maybe more than we can visually see. And here I show you the example of spike rates quantification based on the interictal ECG recordings. And you can see that immediately we have the impression that it's really something very focal, focused on the lesional site on the left orbitofrontal cortex. But if you have a look now to her ictal quantification performed by using epileptogenicity index, as Fabrice explained you. So here we see that it's not only the lesional orbitofrontal region, which is very highly epileptogenic, but also the anterior insula. So we have really here the organization in the network from the very beginning of the seizure. And if we add to these parameters which relate to the excitability, also the functional connectivity evaluation at seizure onset, here it is based on the nonlinear regression analysis by H-square. And we combine this measure with epileptogenicity index in a single measure. So we call it connectivity epileptogenicity index. And you can see that the network involved at seizure is even wider, and includes also some frontal lateral cortex and also some temporal polar and posterior insular regions. So it's really difficult, even using these quantification approaches, But at that time, we based our final decision on the clinical analysis and the epileptogenicity index quantification, and proceeded to the surgical rejection of these two regions, left orbitofrontal and the left anterior insular regions. But now I show you the results of the virtual epileptic patient modeling of this case. This patient participated to RA2 EPINOV trial, but he was in the control group, so we did not have these modeling results for our surgical decision. And what is really important to see here that the virtual epileptic patient modeling here reproduces perfectly the regions already quantified by epileptogenicity index and by clinician, so the insular and the orbitofrontal cortex, but it shows us additional region which was not considered by clinician as epileptogenic and was not also quantified by EI. So it's inferior frontal sulcus here. And so if we now look at the surgery, of course the surgery was performed guided by the decision of clinician, and you can see that all the contacts which were highly epileptogenic according to epileptogenicity index quantification were rejected. So we have the rejection of the left orbitofrontal lesional region and also of the anterior insula. But unfortunately, the surgical result was not good, and patient relapsed already 1 month after surgery, having again daily nocturnal seizures. And the histopathological examination revealed the dysplasia, which was supposed to be there in the orbitofrontal cortex, but no lesion in the insula. So it was really, again, very complicated for us. And so we wanted to have a closer look again to the modeling, and we had the right to look at the report 1 year after. And we noticed, of course, that the non-resected region detected by Webb was inferior frontal sulcus, which was already seen by the source imaging in the phase 1. But now we performed again the magnetoencephalography 1 year after surgery, and we found sources just close to this region in the frontal operculum, but also in the anterior insula. And so we decided to proceed to the second resection, guided actually by this VP modeling and by the MEG. And we also performed per-operative recording to ensure the good resection of all the excitable regions. And finally, up to now, we have this very happy end story for this lady who is now seizure-free since 6 months. So going to conclusion, of course, quantification of the epileptogenic networks is very valuable and very crucial, not only in research, but in our clinical practice. And we can see by this case that we can use both model-free and also model-based methods, which are complementary and also can be completed by some non-invasive whole brain imaging like magnetoencephalography and high-resolution EEG. But our future directions for clinical use are development of really mini-invasive approaches to aim the whole network, such as in silico surgery based on digital twin modeling framework and personalized neuromodelization approaches. Thank you very much for your attention.
Thank you, Julia. Yeah. If we have time at the end, we will allow 1 or 2 questions. It's a timing question. John? Yeah, just a second. This was a very, very clear presentation to show you a little bit what the workflow in the clinic can be. Any comment, Samin, from the patient's perspective, from the people who are candidate to surgery? Any points that you would like to highlight?
I guess not. I've never been a candidate for surgery. I think the only comment I would add is I speak to a lot of people with epilepsy, and quite often people feel like, oh, I've got epilepsy, I'll have some kind of brain surgery. And it takes a little while to kind of get through to people that actually not everyone's a candidate for brain surgery, and there's an awful lot of testing and going through different procedures to see whether they are. So sometimes they'll be months down the line and then find out that actually they're not a candidate for surgery at all. So it's a difficult path, but for sure the ones that you treat absolutely appreciate it.
Thank you. So again, acceleration of the process is an issue.
Yeah, and I think Stephanie mentioned it in the previous talk. I think one of the biggest challenges within the work that everyone here is doing is getting treatments into clinics and actually making a difference to people's lives.
Thank you. John, Professor John Terry, why don't you have the final word? John's perspective is a very particular one. He is a mathematician and an expert in nonlinear dynamics who has really embraced the field of epilepsy. John. Does the mic work?
Can we get it going? Here we go. Great. Listen, thanks so much for the opportunity to speak, Vic. And just by way of full disclosure, as well as my academic role at the University of Birmingham, I am co-founder and managing director of a spin-out Neurognostics, which are developing decision support tools for diagnosis and management of neurological conditions. So when you hear the results I present, do bear that disclosure in mind. So as we heard from Simon, who put it so eloquently and so passionately, many people with epilepsy feel that they're stuck in loops. It takes a long time to diagnose epilepsy. That time, on average, is greater than 1 year. It has really high misdiagnosis rates. They're estimated to be more than 30% in non-specialist settings. 50% of people are continuing to have seizures 1 year after treatment, and 30 to 40% never respond effectively. And these loops are there throughout the system, and as Simon put it, it was 20 years before a combination of drugs were found for which he responded to effectively. Yet other people, after 20 years, nothing works and they become candidates for surgery. You know, how can we accelerate that time to the right decision to be made for the right person? It's a real challenge. So seizures are increasingly understood to be due to pathological brain activity that emerges from large-scale brain networks. And as such, EEG is a primary diagnostic tool. And ideally, what we're hoping to see are signatures of seizures, such as discharges or spikes, that will enable us to be more confident in concluding that this is someone with epilepsy. But there's lots of problems here. As Simon mentioned, these sorts of features are actually present in fewer than 30% of routine EEGs. They're really easy to mistake for other features that are not in fact spikes. So for example, wicket spikes are a really common feature of EEG that aren't actually spikes but could be mistaken for spikes. And critically, these features are actually present in around 3% of the population who don't have epilepsy. So there's lots of potential for misdiagnosis as a result of these clinical biomarkers of epilepsy. And here's the ultimate problem, that the vast majority of the time, the EEG looks like this. If I collected EEG from someone without epilepsy, I'd see something like this. If I collect it from someone with epilepsy, more often than not, I see something like this. How do I tease that apart? So I want to talk really about digital biomarkers. Can we actually reveal features from these recordings that suggest an increased susceptibility to generating seizures, even if we don't see pathological features per se in the recording? Now, I'm going to be using mathematical models. Now, we've had quite a few talks already in this conference, not surprisingly, about mathematical models, but I just want to make a few observations on mathematical models, because we all present with complete confidence in the approach we're bringing, but the reality is that, in fact, there are implicit and explicit assumptions underlying our approaches, and different styles of modeling. So, for example, Wiener classically quoted that the best material model of a cat is another, or preferably the same cat, the idea being that we should have a very detailed model that includes all of the information. In contrast, Einstein said a model should be as simple as possible, but no simpler, so going the complete opposite end of the spectrum, reducing everything as much as possible. George Box, the famous computer scientist, said all models are wrong and some are useful. And Thaddeus Tarpi, a medical statistician in the States, updated that and said all models are right, but most are useless. So where do we sit in this spectrum? So on one hand, we've got reduction, we've got really detailed. In the other dimension, we've got useful and useless. Where in the middle can we meet in order, as one of the earlier speakers said, we can make predictions that have real value for patients? So I'm going to just describe really phenomenological models. I'm not going to go into great detail at all. The brain, as we know, is extremely complex, but we're working clinically with very small sampled EEG recordings. And here's just an example of a single channel of an EEG with a number of spike wave discharges in about 10 minutes of EEG. Now, if I'm looking at the brain at this level of description, I'd argue that I don't need a really, really detailed model. In fact, I could do a pretty good job with a quite straightforward mathematical model. Now, I appreciate not all of you are mathematicians in the room, and looking at an equation like this may already think, well, that's not that straightforward. But this is actually what is termed a canonical model. So it's a model that is the simplest way of describing a particular feature, which in this case is the coexistence of a steady state, so something that looks like this region, and a high amplitude oscillatory state, something that looks like this region. And here's the output of it. I've tuned some of the parameters, and I can get a pretty good agreement between the sort of clinical observation that you might observe and the model. Now, as we mentioned, with clinical EEG, typically in a first seizure clinic, you might have 20 channels, but you could have high-density EEG up to 256 electrodes. So obviously we need a big mathematical model for that, not just a small one for the single channel. But actually it's the same principle, but now I'm adding in features that I can potentially inform from the EEG itself. And I have this matrix, this adjacency matrix defined by M, which tells me how different regions of the brain connect and communicate as determined from these signals. And just very briefly to illustrate it, just a really simple brain here, my brain, it's only got 4 regions. If we look at the output of this particular network configuration, dynamic configuration, there's no apparent discharges, so we conclude this was a normal brain. Yet with just a very small change, I make one region of the brain slightly more excitable than the others, and suddenly generalized discharges appear in the brain. But conversely, if I have all of the regions with the same excitability but change the network structure a little bit, similarly, I end up with generalized discharges. And this is a really important point to note, that subtle changes in either network structure or brain dynamics can both support the same types of emergent dynamic feature. And if we're using that emergent dynamic feature to make decisions, clinical decisions, it's really important because that means there are different mechanisms underpinning the decision, and the treatment choices, for example, for those may be different. So how do we use this approach to calculate a digital biomarker of seizure risk? Well, essentially, we can collect EEG in clinic or at home using dry electrode sets. We don't worry about whether there's any epileptiform activity. We just assume that it's background-like activity, perhaps an alpha rhythm present. And we create a brain network by considering correlations effectively between the EEG channels, and this informs a computer model that essentially enables us to generate a person-specific proxy of the EEG, from which we can understand how easy is it for seizure-like behavior to emerge. And we can study other properties of the network, so for example, spectral properties, brain connectivity, alongside those computer model properties, and combine those to produce an overall seizure risk score. So we looked in a study of over 800 EEGs from around 600 patients who went to hospitals suspected of having epilepsy and either received a diagnosis of epilepsy or a differential condition such as non-epileptic attack disorder. And we then considered the subset of these cases for whom the first EEG they had was clinically non-contributory, i.e. you couldn't reach a decision at that point and they had to have further tests down the line, often long-term monitoring in a video telemetry unit before a diagnosis could be reached. So sensitivity in this test, 0, which, as Simon mentioned, is really challenging for people. In contrast, this model-based approach, just using a fairly straightforward model, produced sensitivity from these apparently non-contributory recordings of 0.62. Now, if you contrast that with the sensitivity you get from EEG across the whole clinical pathway, so as many EEGs as you want in order to try and capture these features, you don't achieve that level of sensitivity. So I think it's a really promising approach for actually revealing these hidden features from apparently normal EEG. We've also got preliminary results as to how you can use this approach in prognosis. So, for example, if you take an EEG prior to and post placing patients on anti-seizure medications in cases where they respond, the risk score drops statistically significantly from the baseline score that they have. We've also published results working with colleagues at the University of Melbourne in the surgery space as well, using similar approaches to those described by Fabrice, but using MEG signals to inform networks and then guide surgical decisions. So I hope that's given a very brief overview of the sort of approaches we're bringing to bear. Here are some of the references, and if you want a bit more of a gentle introduction to our work, this Nature profile on how diagnosis of epilepsy can be accelerated is well worth a read. Thank you for your time.
Thank you. Thank you, John. Thank you very much. We are perfectly in time. We started a little late. Nevertheless, the lunch is out there. Is there one burning question that you would like to ask now of relevance to the audience also? And if not, well, yeah, but you have to come to the mic if you want to. Yeah? So one question, and I also want to emphasize that all of us will be available here, some of us for the rest of the conference, and definitely later for the lunch, and open for questions. Please.
Thank you. Given that Victor said a burning question, this is a burning and a bit provocative question. And considering that the efficacy of the surgery is related, most of them, to the identification of focal cortical dysplasia, tuberous sclerosis, alteration of the structure, and then also of the diffusion of the, let's say, of the seizure in the source. And especially considering what Professor Bartolomei said, that it seems that we reach a top-level identification of the seizure onset zone. Can it be that the surgery itself may be limited only to certain kind of epilepsy, and the other treatment are necessary, like neurostimulation or genetic treatment? And let's say that the effort that we put into much in the identification of epileptogenic zone can be in some way also directed to other direction. I don't know, it is a bit provocative.
No. I think you are perfectly right. We have a ceiling glass with epilepsy surgery, and it's probably linked to several factors. One factor is probably what I developed is we can progress in the better knowledge of what is epileptogenic, what is not epileptogenic in the brain, and how we can adapt better classical surgery. Okay, there is, I think, some minimal margin of progress here. The other point is what you mentioned is the genetic factors associated with some focal epilepsies, and of course, if we have a genetic disease, the surgery is more difficult. And if you have a focal surgery, you can imagine that it's not so efficient when you have a mutation that affect the whole brain. But sometimes we have mutation, but we can identify the region that is more epileptogenic, and the surgery can work, not completely, but can improve the patient. And of course, what we have to develop is other techniques, and neurostimulation. You mentioned neurostimulation. There are also, by the network approach, the idea that we can plan intervention, and probably one of the interesting perspective, and we work with just Victor and all the team of Victor in this perspective, is to plan the consequence of a focal resection or stimulation. And you have some posters here. Of course, surgery by just removing a region is a bit rough when we talk about the complexity of the brain. But we can, again, improve this approach and develop other alternative approach. It's very important, yes.
Thank you. Thank you very much. Bon appétit. I'll see you later.
Thank you.